We are going to talk about normal pregnancy and an abnormal pregnancy, and just help us to, gain a better understanding. Panelists here, we have seasoned midwives, we have a neonatal care nurse. A neonate is a baby that's between 0 days to 28 days of life. We also have seasoned nutritionists as well, with quite a vast experience both in the community setting, the public health sector, and also within the hospital setup. So I cannot also ignore the fact that part of this, we also have teenage mothers, surprisingly as young as 10 years, girls as young as 10 years getting pregnant. And, the risks that are involved with such a young girl conceiving and of course delivering. A lot of these issues definitely are culture centered, and we all come from different backgrounds. We have young girls getting married early. We have issues surrounding street families, where you also have young children getting pregnant. We have issues surrounding incest and family relations that are a bit strained. So that will also help us, or rather will be something we will handle and touch on in our discussion today. About 83% of all women who die because of pregnancy-related issues can definitely be avoided and be prevented. And one main thing that can help us do that is ensuring we get proper and adequate antenatal care. Now, without much ado, we'll delve into our presentation for today. So I'll invite Josephine to take us through the definition, and then so we'll have Josephine, Joseph, Grace, Joanne, and Lillian karibuni sana in this deliberation. Yes, Josephine, go on.
Thank you so much, Joyce. And thank you to our participants for finding time to come and learn together. So today it's about normal and abnormal pregnancy. The last time we talked about preconceptual care, and we said that a healthy and a normal pregnancy starts before conception. This is a continuation, and we are saying that a normal pregnancy is a pregnancy that involves one fetus, one baby. It is also a pregnancy that occurs intrauterine. This means that the implantation of the fertilized ovum, which forms a zygote, and later continues, grows to become an embryo. Eventually, that's what we call a fetus. It's called a fetus before the baby is born. And after birth, then we have our baby. So that intrauterine pregnancy that is implanted well in the uterus and not in any other place, but in the uterus, is a normal pregnancy. The gestational age goes all the way between 37 and 42 weeks. So here we say any baby that is born after 37 completed weeks. A week being 7 days, then we say should go up to 40 weeks. So if a week is 7 days, how many days are 40 weeks? So this is simple mathematics of 4 times 7 is 28. So normal pregnancy takes around 280 days. So a baby might come at 280 days, another one might come at 236 days. So that is the 236 days is preterm because has not completed, isn't it, the days, or slightly above that. But again, because of various factors of pregnancy, there are those who will come a bit early, there are those who will come later. But today we are not talking about the early and the late, we are talking about the normal one. So if a fetus completes 37 completed weeks and to 40 weeks, then the 2 weeks is a grace period. Really, if they are born after 42 weeks, then you expect changes to occur. Again, it becomes abnormal. So the baby has to come at its right time. Normal fetal growth and development. So this has to be monitored to ensure that as the weeks go by, the fetus is also growing and undergoing development. If there is absence of major medical issues in the mother and even obstetric complications and emergencies, then it is termed a normal or a healthy pregnancy. Normal maternal physiological adaptations to pregnancy. Again, we appreciate that the body changes throughout pregnancy. This increases a strain to the organs of the mother, but if the mother's baby is able to cope with this well in a normal way, then we end up with a normal pregnancy without medical disorders or obstetric emergencies and normal physiological adaptations of the body. Then spontaneous onset of labor, and by the word spontaneous, again, we mean labor that comes on its own when it is time, without being induced, without any induction, without coming early, and having a vaginal birth, which is a normal delivery. Though we still appreciate that a normal delivery might end up in a cesarean section, again, if the reason for the cesarean section is justified, not just for the sake of it, but having an issue that arises that would want the healthcare team to perform this kind of operation to ensure that the mother and the fetus remain safe and healthy.
Wow, thank you, Josephine. That gives us insight on what is a normal pregnancy. Yes, Lillian, I see your hand is raised.
When you say singleton fetus, that's a normal pregnancy. Does that mean anything more than one? So if someone expecting twins, automatically that pregnancy is not considered a normal pregnancy?
In the medical field, we consider them as risky, special outcomes. It is not normal. You'll find a fetus getting fertilized and growing as one, but now something will happen that will make the ovum that is already fertilized to divide. Many things like genetics play a major role here, and having two, which is twins, is quite common. Nowadays, even having three is common, but you rarely find 4 and above. People who use fertility medications will find themselves having abnormal multiplication. So that's why you'll find when a normal pregnancy is being defined, just one is used. If multiple pregnancies occur, then the dynamics of also taking care of such a mother and babies become complex, and therefore they shift classes to a special group of people. Again, they are rare. Though nowadays we tend to see them a lot. For someone like Joseph, who is in the labor ward, what is the incidence of these multiple pregnancies nowadays? We are almost now calling them normal.
Actually, thank you for sharing. That question is a good one. I think what we are saying is there are those pregnancies which need special attention, so that these are not pregnancies which at times should be handled at a small facility, because there are very high chances of these mothers having some issues either during the pregnancy or at delivery. We have sometimes if you attempt to deliver in a local facility, the ones we call level 2, level 3, meaning they don't have a theater. You might have a problem. You might deliver the first twin quite okay. The second one is retained. You might need to open to do a cesarean section. So that's why they go to that area, so that people know you should have a follow-up in a more specialized facility. We have issues sometimes. The twins, we can have what we say, you can have one twin getting more blood from the other. So one twin might have anemia when they are inside the uterus. So we have quite a number of areas that we like to think about when we are talking of the twin, which you are not going to have when you have a singleton. Thank you. But the rate you had asked about how often sometimes we have these risk factors. I mean the ones which can be able to bring maybe like the family history of twins on either side. But these times, because of the way at times we are even having the IVF as a way of getting pregnancy. In most cases, when people are doing IVF, they prefer aiming at having twins. So the twins, generally the numbers must increase. Thank you.
Thank you for that question, Lillian, and thank you, Joseph and Josephine, for your input. For sure, it's not that the mother is sick, that she has multiple pregnancy, or rather more than one fetus in the womb, but just that she'll need extra care, extra attention, because of the complications surrounding having more than one baby in the womb. So I will invite Joseph to take us through the next slide. We have a new person joining us. I'm not sure I can see their name. Olive. Welcome, Olive. Glad to have you here. So, karibu sana. Yes, Joseph, take us through the enablers.
The first one is our routine antenatal care, which is really encouraged. We have moved from our normal 4 visits to 8 visits, which at least gives us more advice on the mothers, starting early and also doing the follow-up until we are approaching the delivery. So as we are doing that, as we are going to see in the next slide, we have talked about those main issues that we usually pick. So we are going to see them on that other slide. On the nutrition, today we are happy that we have our nutritionists on board. We really welcome them so that they can give us the approach on the nutrition from the specialized team. So I will not dwell much on that. They are going to give us on their slide. On our iron and the folic acid supplements, we have research has shown that at times we are having defects on our babies, which are as a result of the deficiency on this line, which we really want to make sure the mothers get the advice early and they can benefit. The babies are going to be born most probably without deformities. For the psychological and the counseling, it is quite a good one. So we have the components on the emotional support. We have the health education and the counseling. We have the mental health, the screening. We have the stress management and the coping strategies, and also the social support. At times, we might realize at the level we are in, maybe the symptoms our clients are having might need referrals to the specialized facilities. Why we talk of the specialized is because at times a pregnancy might require multidisciplinary approach of the caregivers, and in most cases that's where you see our level 4s going up. We are able to have people on the special fields who can really be of a lot of help. Times you might have a mother who is already on some medication, or there is a history of a disturbance during the previous the delivery. After that, during the puerperium, there was the psychosis. There is a mental disturbance which comes when the mother is breastfeeding, there is a high chance of having a recurrence during a next pregnancy. So it's very important for us to be able to talk of that. Exercises are very vital, unless otherwise contraindicated. We should have exercise to this mother. For the rest, the sleep also very important, that our clients are advised to have good health, good rest, and sleep. Issues of alcohol, at times people ask whether there is any safe amount of alcohol that you can take, but from what has been there is no research which has shown that there is any amount of alcohol which is safe. The same with the smoking, the same with self-medication. Why we have this is that these drugs can cross the placental barrier at the enter on the circulation of the baby, which is going to affect the development, especially on our brain. So alcohol for the baby, the liver is not mature, so it cannot be metabolized at the move out. So if taken, it is going to affect our development, which leads to quite a number of complications during the growth. So at times it can lead with having deformities. We can have premature deliveries. We can have a death in the uterus. So there are quite a number of areas that this one affects. Then it's very important for us to know why we are really having this presentation, is to let our clients know that they need to know the danger signs, and they be able to get help early, because there are those things that we feel if people can be able to get the information, it is easy for us to avoid the complications, which are sometimes they look quite obvious. Thank you, Joyce.
Awesome. Thank you, Joseph. Maybe as we proceed, I will request participants, if you can type in the chat box, what are some of the myths or, common stories that you've had surrounding pregnancy? For example, a pregnant mother should eat for two. Is that true or is it false? Let me know what you think in the chat box. When a mother is expectant, if now we've talked about twins or triplets, if she has twins, she's carrying twins, should she eat for three? You can just put a comment in the chat box, when we will definitely help to demystify some of these things. And then I wanted to ask Joseph or Josephine or the rest of us who can answer, does the man or the spouse or the partner or the father of the baby have any role to play in this journey so far?
The father has a lot of influence in the health being of both the mother and the baby during pregnancy, during delivery, and also during the period when the mother is at home. The father does a lot of help. As we are saying, we should avoid alcohol. It means that alcohol, we know, is one of the areas that spend a lot of money. And during pregnancy, actually the finance issue is very important. There are quite a number of things that the family might need to buy and be prepared. So when we talk to the fathers, we really encourage them. Antenatally, when we are saying that we would want to have the prevention of diseases like sexually transmitted diseases, we have to involve the couple, and all the facilities need to really make the fathers and the spouses feel comfortable when they come to the clinics. They are very important at the moment. Even in our labor wards, we have encouraged mothers, they can come with their spouses as companions so that we can be able, they can give support even in the labor ward, and we on discharge we also advise there are quite a number of help that the process can really give, especially sometimes we have the deliveries via cesarean sections, and for the first days the mother might need a lot of support from this process. So it's true, they have a big role to play. Thank you.
Thank you, Joseph. So our next slide, handle still talks about antenatal care. Do you want to just highlight just a few key things, some of the investigations that are done and the why behind them?
We have our antenatal booklet. These days is a very nice booklet which has captured what we need to do in the antenatal visits. During the delivery, the documentation we should put, and also during our postnatal visits, especially for the well-being of the baby up to 5 years. So for now, we are going to capture on what we are seeing on our slide, whereby we have the general information that we usually fill. I think we can see what has been highlighted in red. In yellow, which are the key areas that we really like having.
Some of the tests that are done, we have hemoglobin or HB, which checks the blood levels in a mother. We have the blood group, which is tested to just know and confirm what blood group she has, whether it is A, AB, or O. And then there's the rhesus factor. It's normally either rhesus negative or rhesus positive. Urinalysis is the other test, which is simply a test of how the mother's urine is tested. What do we check for? Protein, infection, let us know. There's also a random blood sugar, which is also sampled in the blood. There's also screening for tuberculosis, TB. An ultrasound is also mentioned. The first one done before 24 weeks, preferably at about 20 weeks. We also have a second and a third one, a second one also done in a second scan, ultrasound scan done in the third trimester. There's also testing for HIV and syphilis and hepatitis. Those are the main tests that are highlighted: HB, blood group, rhesus factor, urinalysis, random blood sugar, screening for TB, tuberculosis. There's the obstetric ultrasound scan, first one done at 20 weeks preferably, and another one at third trimester. There's testing for HIV and syphilis, and then there's also testing for hepatitis.
So actually, those ones highlighted in yellow, they are very important, starting with our level of the hemoglobin, so that we are sure we are not having anemia, and we can be able, in case it is there, we can be able to correct it early. We have quite a number of causes of what can have us having anemia. It might be as some of the simple issues, like maybe what we can be able to test from the stool, so that in case of worms, we can be able to manage. But there can also be some complicated issues which our hematologists can be able to come in.
Sorry to interject. I have Grace, who is joining us as a nutritionist. She needs to leave to attend to another function. If we will just invite her to share briefly, then we allow her to proceed. Then you can proceed, take over after that. Go ahead, Grace.
Thank you so much, Joyce. I hope I can be able to be heard. And so I just wanted to emphasize that it's important for all mothers before even pregnancy, that is pre-pregnancy, to be in good nutritional status. But most of the time you'll find that huwa tu tunashtukia a pregnancy is already there with us. So it's important to ensure that we are in good nutritional status so that we can have good outcome or better outcome. So in pregnancy, I've seen a comment, eating for two. Yes, it's important that we need to know that other than the normal kilocalories that we expect a normal adult to take, we need to add extra. Why? Because we would like to take care of the nutrients that are actually being donated to the fetus, and even for our own nutrition status. So we add 500 kilocalories per day of whatever we are eating. And that is why when we talk about nutrition, we talk about the 10 food groups according to FAO, the and World Health Organization standards, that we take the 10 food groups. But out of the 10 food groups, maybe one of these days, if we are not aware of the 10 food groups, I'm not so sure, but I hope we are aware of them. But maybe one of these days we can actually talk about them. But the thing is, out of the 10 food groups, a pregnant mother needs to ensure that they take at least 5 of the food groups. So if I could have had a little bit more time, I could have explained further than that, but maybe next time. Otherwise,
I have a slide showing on
Yes.
nutrition. Maybe you can
Okay.
have a look and see some of the foods that are listed there.
Yes.
Mm.
Yeah. So and then now to have at least three main meals. That's breakfast, lunch, dinner, and 2 snacks and 1 extra meal. That 1 extra meal is what is going to that 1 extra meal and 1 snack is actually what is going to take care of the 500 kilocalories that we are adding on the normal. And especially when the mother has gotten into pregnancy, when their weight is a little bit on the lower side or within normal. Then after pregnancy, that is after delivery, we again do 3 main meals, 2 snacks, and 2 extra meals. On the iron supplementation, at least that one we are aware that it's mandatory for all women to be on folic and iron supplementation. Yeah. But it's important that also, as even we do supplementation, we also take in foods that are actually high in iron, so that we do not get anemic mothers. Otherwise, thank you so much.
Awesome. Thank you, Grace, very much for your input. We appreciate your time and do recognize you have another function ongoing at the same time. So asante sana for making time to join us. Okay, Joseph, I
So
think
I'll just be listening in and checking the chat boxes, so that in case of anything, I can step out just to answer. That is, if I have time. Sawa sawa.
that's okay. Thank you.
Thank you.
Thank you for your comment, Olive. A mother should eat for 2. There's need for extra nutrients, yes, but modestly. I think Grace has clarified on that. It's your normal regular 3 meals, but then add 2 small meals, extra meals in between as a snack. And of course, the idea really is that you have adequate nutrition. She has mentioned 10 food groups. I think we'll get there, but it's what is showing on the slide right now, with local examples, from food stuff that we can find within our immediate vicinity. Do pregnancy cravings indicate nutrition deficiencies? I believe we'll have that question answered as we proceed. And also, I'm also curious to know about these stones that women eat, the ones that have been eaten for years on end, if they're helping to satisfy any nutritional deficiency. So I will let Joseph finish up on this slide, then we can proceed now with a bit more detailed discussion on nutrition. Joseph, karibu, if you're still there, please proceed.
Thank you, Joyce and Grace, for that insights. We had talked about our HB, which guides us on whether we might be having anemia in pregnancy, which we should be able to correct early. Because if a mother is anemic, it means that the baby is also not going to get the right nutrition that we would have expected. So in case of the anemia, we have agreed it should be corrected early. We must establish the cause, so that we treat the cause, so that we don't have a repeat, and we improve. Because during delivery, it is quite a high risk in case we are going to deliver a mother who is already having anemia. As expected, there should be blood loss, so it worsens when a mother has anemia. On our blood group, we usually do it so that it can also help us on the third highlighted on the resource factor. Why we really look at the resource factor, we are interested with knowing whether we have a negative or a positive, because there is usually a problem when we have a mother with a negative resource factor and the spouse has a positive resource factor, which means there is going to be what we call the resource incompatibility. So this one, especially for the first pregnancy, if it is pictured, it is usually very good, because we can be prepared. There is what we give, there is a drug called anti-D, which is given at 28 weeks. So why it is important to note it is because it might not affect the first pregnancy so much, but now, because if there is a problem and nothing was done, the consequent pregnancies are going to be affected. After delivery, we usually test the baby's blood, because we at times we avoid pricking the baby, so we usually take what we call the cord blood. So we usually advise the mother during labor to remind the midwife that she is resource negative, so that we can remember to test to know whether the baby, the blood group will be resource negative or a positive, whereby if it is a negative, we are sure we are not going to have the problem that we had anticipated. If it is positive, we usually give the anti-D before 72 hours after delivery. This anti-D is a bit expensive at the moment. At the market rate, it is costing about 80,000. So as we had said about the finances, when we test when we do this test early, we can start advising the parents early, so that they can be able to save. We don't go into problem when we are trying to tell them that we need them to buy this drug for 8,000 as emergency. So it's good to have them. We know we have the insurance, but sometimes insurance doesn't cover everything that is required for the mothers, especially these mothers who have these risk issues. In most cases, they are going to be referred to higher level of the hospitals. And as we said, there are mothers that we talk of having some risks. So we like them being managed at a hospital with what we call the multidisciplinary teams, because these babies whose mothers have issue, we always involve the neonatal team. So in our setup, when we have tested for the hepatitis for the resource, when we have the resource issue, we always, during the delivery, we make sure that we involve the nutrition the neonatal specialists. So for the urinalysis, it's a routine that we also do. Sometimes you can pick some infections from the urine. Sometimes you can pick some abnormalities. Maybe you have what we call the proteins in urine, and they also help us to know whether there is any underlying issue. For the blood sugar, we know at times we might not be knowing whether we have diabetes. At times, chances are that it's very rare for a healthy person to go for this normal screening, which should be the ideal. So that's why when one is expectant, we need to really capture this. So why we do it early is because somebody maybe have been diabetic when you are not expectant, and during the follow-up, you can turn to have diabetes, which we call gestational diabetes, which is a diabetes which comes because of that, because of the pregnancy. So we really need to know so that we can be able to have the controls. So when you had already known that you have diabetes, when we test that, then we see the sugars have an issue, there is a further test that we can do so that we know during the last 3 months, have you been having sugars which had a problem? And also quite a number of screening. And that's what we say, that a mother with this type of condition, they need to be followed up by the special doctors who usually deal with the diabetes. For the TB screening, in most areas, TB is quite common, and as we know, during pregnancies, our immunities are a bit affected. So sometimes the TB can be able to get room to affect you. So it's a very important place. At times you can get pneumonia as a sickness, and because sometimes the presentations are the same, you get difficulty in breathing. So we always like knowing, might you have been having a history of TB, which might be the cause, or might it be any other issue like heart conditions? They also present with a difficulty in breathing. So that's why some of these screening are very important, so that in case we get any other symptoms as we go on with our pregnancy, we can be able to know when did these issues start. If you get the problem and we already had known that you have TB, we could have been able to know it might be the problem which is recurring. On the treatments of the TBs, when initiated well, you can be able to cope with the pregnancy as you continue with the treatment. So for the ultrasounds, they are very important, especially sometimes we get expectant and we have not been able to establish maybe through your last monthly period. So at times you just realize you have a pregnancy which you had not known. So it's good to have a fast ultrasound so that it can help us to know the gestation. The earlier the ultrasound, the better for us to know the gestation. That's why the first one we are encouraging it to be done between the 18 to 20 weeks of the gestation, and the second one during the third trimester. So
allow me to ask, what are some of the things they check in this ultrasound? Why is it important to have the scan?
So the important things we have said, one is to help in confirming the gestation. Then we have what we call some fetal anomalies which can be picked early.
Mm-hmm.
We can be able to pick maybe multiple gestation. Currently, we have the specialists, our obstetricians are currently specializing in what we are calling the maternal fetal management, whereby they can be able to handle the management of the babies who have been noted to have issues when they are in the uterus. So there are those we have even gone to the extent of doing some transfusion. So it's quite it is actually quite a good thing when things are noted early. So we have those doctors currently who are able to give a lot of help for any abnormalities noted to the baby when the baby is still in the uterus.
Okay, so even congenital abnormalities can be picked up early.
Exactly, they can.
And there are those that can actually be treated, or rather there are conditions that can be treated on the fetus, on the baby when it is still in the womb.
Sure. And also now when you are doing the delivery, we can involve the neonatologist to be on the standby when we are doing the delivery so that they can pick up the baby immediately after the delivery.
Awesome. And I'm sure now the third trimester, the last 3 Is that a quarter? The last 3 months of pregnancy, when the lady has the scan done, what are some of the things that are observed, aside from the gender of the baby, which I know many parents would be excited to already know before the baby is born. But at the third trimester, what do we look out for?
So at the third trimester, we can have the guide on the mode of delivery. We can have babies who are overweight. We can have babies who are born even up to 5 kilograms. So these are babies that we can be able to plan to deliver via CS from our findings. Then we have talked of the congenital anomalies. Yes. There are those babies who we talk about bleach, or in the general language we talk of kuketi. In total,
when the baby is positioned with the buttocks coming first instead of
exactly, that's the one that we are calling the bleach. So bleach presentation. Currently, we don't advocate for a vaginal delivery for a bleach presentation, unless
all mothers or just first-time moms.
All mothers.
Even the one who's coming for the third baby and a fourth.
All mothers.
Okay.
Yes, because sometimes you can have the conditions like the one that we call the hydrocephalus.
Yes, when the baby's
head is big
than normal.
So you can deliver the buttocks quite well, but then you get stuck with the baby's head. So
okay.
So the current position is vaginal deliveries are contraindicated when you have a bridge. So that's these are where we really benefit. Sometimes you can have a bridge from this array from the first ultrasound, which is done maybe the ones we are talking of below 30 weeks. It's a chance that the baby can still turn at the head comes out. But now for the ones which are way above, those are at term. If it's a bleach now, that one we are sure we are going to deliver via CS.
Okay. In the interest of time, allow me to interject, please.
Yes.
But thank you. You have delved quite deeply on what is key in antenatal care. Maybe just to mention is the infections that the mother might have, probably sexually transmitted infections or diseases, things like syphilis and hepatitis, or sometimes even gonorrhea, in pregnancy, or even in the presence of HIV infection. The reason being, we're not checking to stigmatize a mother, but it's mainly to safeguard the baby, because a lot of these infections can easily cross the placenta barrier into the baby and affect the growth of this baby. You end up with a child who has abnormalities, when they're born, or there's intrauterine growth retardation. The baby, yes, may be born at term, but not fully developed. So thank you, Joseph. We will look at nutrition. Grace has alluded to 10 food groups that are important to look at, from which to base our diet, mainly a balanced diet. Lillian and Joanne, you can guide me on this one. 3/4 of a plate should be, or rather a quarter of a plate should be starch. Then you have your proteins and you have your, what else? Do you want to discuss a little bit? Yes, I know your participants, but also you're welcome to weigh in on this one.
Okay, I think let me start and Joanne can add. It should be a quarter plate with protein-rich food, the other quarter with starch, and then the half of it to be vegetable. And maybe just say that when we're talking about weight gain in pregnancy, it really goes with the weight of the mother pre-pregnancy, whether she was underweight, normal weight, or overweight. and the weight gain we expect should be advised. So somebody who was overweight should not actually be seeking to gain what we usually say the normal, the 10 to 12 kgs. It should actually be 7 to 11 if she was overweight. Then the person who's underweight should be seeking to gain between 13 to 18 kgs. I'd like to say that the focus during pregnancy shouldn't so much be on how that plate looks. It should be on key nutrients. We know that there are certain nutrients that are indicated, have some bearing on all mothers. So, for example, what we said, iron and folate, that is going to have an indication on all mothers, whatever your nutrition status was at the start of the pregnancy. And therefore, the focus should be on eating nutrient-rich foods as opposed to how many calories are being taken or how many meals. So if I was to advise a mom, I would advise that look into taking, for example, animal source protein. Make sure at least twice a week you're considering organ meats in your diet. You're considering liver. You're considering, if possible, add some heart when you're ordering for that liver. So those type of organ meats are very rich in nutrients without being too rich in calories. So that would be my advice. I think that's it for now. Thanks. Yeah.
Wow, quite insightful. Thank you very much, Lillian.
I wanted to just clarify, yes, consider nutrient-rich foods as opposed to how many servings of, how many plates of food we are taking, or what we were talking about, should it be 3 meals and 2 snacks?
Yeah.
Yes, that's not bad, but really it's more of, even if you are taking, for example, 3 meals and 1 snack, consider that in every meal, your sources of vitamins are predominant, and then you're taking iron-rich, you're taking the right sources of protein, because and the protein, if they are animal sourced especially, they are going to end up having a diverse combination of nutrients. Your calcium, which is also indicated contraindicative during pregnancy, and then of course the iron and the folate. Most likely those kinds of nutrients come from the same sources. So if I tell you to eat eggs, there you're getting good quality protein. At the same time, you're getting calcium rich food, and not just calcium rich, but it is also rich in vitamin K, which helps the absorption of calcium in the first place, and also the absorption of it's also rich in vitamin D, which helps the absorption of calcium. So you're getting a compound of micronutrients within the same sources. Yeah.
Wonderful. I also appreciate there are certain foodstuffs that, like you said, one will help with the absorption of another. The citric fruits as well help with the absorption of iron in the green vegetables. So I think it sounds a bit mind-boggling right now, but I believe if one is able to sit down with a nutritionist or a midwife at the health facility, just to get some clarity and guidance on how to work around their diet during the journey. And last month we did talk about preconception care. So some of these things really are worth putting in place even before somebody conceives, just to help prepare the body to handle the journey and handle the pregnancy. Awesome. Thank you, Lillian. So I'll invite Josephine. Josephine, if you can just walk us through the key features of how a normal pregnancy should look like. Josephine, take us through the slide very briefly. I see our time is way spent. We have about 15 minutes.
Thank you. Thank you so much, Joyce, once more for this opportunity. What do we expect to see in the mother, the maternal features? What also do we expect to see in the fetus? So pregnancy and its physiological changes brings in a rise in blood pressure. So if our blood pressure is able to be maintained at systolic of 140 and a diastolic of 90, that is the lower part, that would be normal. Anything above this, like having a diastolic of 90, say 5, all the way going to 100, that is considered high blood pressure, regardless of whether it is the systolic or the diastolic reading that we are talking about. There are risks that are associated with high blood pressure in pregnancy. For example, inadequate blood supply to the rest of the body, the mother and the baby, and even the usual complications that you expect in other people who are not pregnant, like a stroke. You also get strokes in pregnancy. Therefore, it's quite very important to maintain low blood pressure. We also want to treat anemia, because you've had, like, from the discussion, it is like, yes, you're eating for two. You're eating because you need the nutrition, and also the growing fetus is getting its nutritional requirements from the mother, actually from what the mother has. That is the only source for the baby. Then when you test urine, there should be no protein in urine, because when you find urine, you'll know that when you find protein in the urine, it's evident that there's leakage of this protein from the kidney, which is not normal, showing inflammation and even a mark of what we call preeclampsia. So the diagnosis of preeclampsia mainly is by showing a high blood pressure, showing a lot of protein or even a trace of protein in the urine, also accompanied by edema or water depositing in the body. So there's what will be in the lungs, and the mother might present with a cough, but very commonly you'll see, especially the extremities, the feet, getting full of water. But nowadays you're saying even one sign, like blood pressure, accompanied by either the protein in urine or just the swelling. It's not a must that we see the three of them to be able to say that now the mother has preeclampsia. Normal blood glucose level, which we measure in milligrams per deciliter. We also have a unit of measurement that is in millimoles per liter. And a normal one is 3.5 all the way to 7. So if we find blood sugar level of 7.5 going upward, then again, the mother has a high blood glucose level. Again, it is common in pregnancy that one might have a normal blood sugar records, but then in pregnancy, they shoot, and after pregnancy, they go back to their normal blood sugar levels. That happens quite a lot. There are no signs of infection or any other danger symptoms. An infection to the mother is a danger sign, because it can lead to spread of infection to the growing fetus. So for the fetal development, what we monitor in the antenatal period is the fundal height corresponding with the gestational age. So as the days go, as the mother adds weight, this shows us how the fetus is doing. The well-being of the fetus, because it is a fetus that we can't see, it is growing inside the mother. We are able to measure the growth of the fetus, especially in weight, through the mother. Now, when we do the scans and we are able to do the measurements of the length, the hand circumference, the arm circumference, that shows us how well the baby is developing, and it should be correspondent with the gestational age. Fetal movements tells us that the fetus is alive. The heart rate is there, which is a normal of 110 to 160. In case of a heart rate that is higher or lower than this, we make a diagnosis of fetal distress. We'll know that there's something that is obviously wrong with the baby. Normal amniotic fluid volume. The baby grows in an environment that has fluid, and the baby just swims throughout the entire intrauterine life in this fluid, which is called amniotic fluid. Again, it should not be very little and it should not be very much, because we have conditions whereby we get these situations. and then the cephalic presentation at term. The baby will keep turning and taking different positions in the uterus, but by the time it is getting to the third trimester and almost getting to term, then the head should be at the lower uterine cavity, so that during birth, the head comes out fast and not breech or not lying transverse or across the uterus. This is what we call a normal fetal position. So these are the key features of the mother and the baby that you find. So this is where we are talking about the normal pregnancy. Now, when we talk about the abnormal pregnancy, then you'll be able to appreciate what becomes abnormal or what is not normal.
Maybe just to point out, when we say normal fetal movements, here we encourage actually the mother to be able to monitor how her baby kicks. Guide me, Joseph, on this one. What is the best gestation to start assessing the fetal movements or the fetal kicks? And yes, there's a fetal kick chart where moms can just record the time of the first kick and the time of the last kick, just to help her check on the well-being of her baby. Every baby is different. Every pregnancy is unique to the mother. But yes, what's your guideline on the assessing normal fetal movements?
Thank you. What we do is that when we talk of the danger sign of the fetal movement, the mother usually notes the movements from her side. There is a problem. We always advise, first of all, she comes for checkup. We do an ultrasound just to be sure there is nothing worrying. From there, we advise to have the fetal kick chart for our monitoring from the mother. So what is the general guide is that we do it during the day. So we don't consider it at night, because we also assume the mother is sleeping. Now for the day, we like her ticking up to 10 kicks during the day. So once you achieve 10, even if you achieve it maybe by 3 p.m., we are happy. Once we achieve 10, we are okay. So the number is 10, and the time is during the day, so that we are not going to be worried because she had kicked at night and maybe at one time she sleep, because we also expect the baby to sleep at time. Thank you. Actually, the kicks start early. Maybe I can. The kicks should start very early, because these kicks, when we our main issue is we can have a loss of a baby in the uterus at early gestations. So that's why the movements are important. Those movements now, by the time now we go above the 20 weeks, what happens is that in some developed countries, the survivals of the babies starts as early as at around 22 weeks going up. In our setup, usually have a better survival when we are at 28 weeks, but we still have those ones who have been surviving from the experience at the moment, which Josephine can tell us that even at 26 weeks, sometimes at 24 weeks. So we always give a leeway, even if the chances of survival should be 50-50. So why we might not have a lot of the interest below the 20 weeks is because the survival might not guide us so much. But now when we are approaching the above 24 weeks, at least it is more significant for us to know that there is also the salvaging of the baby if the situation, the survival in the uterus is worse than when we are in the newborn. These are the areas that we usually count on. Thank you.
Okay, awesome. Thank you. Now that you mentioned premature babies, Josephine, would you like to point out just a few things that a mother would need to know or the risks of a baby if the baby is born before 37 weeks. I think when we started, we did mention or allude to a term pregnancy. A fully grown baby is considered term. A pregnancy is considered term from 37 weeks. So if a baby is born earlier than that, what are the risks that are involved, and is there hope for that baby? Can a baby born at 28 weeks survive? Joseph has just said even taking it lower to 26 in our context. And I will please request us if you would bear with us and allow us to go a little bit extra by about 15 minutes. We will endeavor to finish this call by then. Josephine, briefly touch on preterm babies.
Okay, thank you, Joyce. We specified the period of the pregnancy. Now, a pregnancy that terminates before 37 weeks then is an early birth, is a preterm birth, because a term birth is 37 completed weeks onwards. So now, again, when we talk of preterm birth, how preterm is the birth? At what point did we lose the pregnancy? So again, we have a miscarriage, which occurs early in pregnancy. We have babies born at 20 weeks of pregnancy, as early as that. Again, depending on the various causes. We have many causes of preterm births. When we'll be handling that, we will get into the details. And we could have, again, a preterm birth occurring anytime between 20 and 30 weeks. So the nearer you are to the 37 weeks as a fetus, then the better your chances of survival. This is what is called embryonic fetal development before the fetus actually is born and comes to us as a baby. During all this time, various changes occur in the fetus. This is when the cells come together after fertilization. Then a lot of cell multiplication happens. Then a lot of differentiation into the many organs that we have into the body. Some of them will go to form the brain, others to form the heart, others to form the respiratory system, the gastrointestinal system, the reproductive system, the skin, the integumentary system, even the hair, not forgetting the urinary system. So all these systems are coming together. So what happens in the fetus is that up to the time of delivery, these organs are forming, especially in the first trimester. Then after the formation, they are now growing and developing up to the time of the birth. So by the time we get to the third trimester, most of these organs have already been formed. You'll be surprised to know that by 20 weeks, actually between 16 to 20 weeks of a fetal life, the heart is already beating. A very primordial kind of a heart is already in place. It's already beating. The cells have been formed together. Then the rest of the systems will come. But now, surprisingly, the respiratory system is the one that forms last. The bronchi, the bronchioles, the alveoli, the areas which are involved in the exchange of carbon dioxide and oxygen. And the respiratory system will develop even extrauterine. After the baby has been born, the child is growing up to 8 years of life. The alveolars are still growing. So you'll find that these children, when they are young, they'll continue to have vifua, homa, asthma, and the parents will tell you that as the baby continued to grow, that as our child has continued to grow, amepona asthma, all these things, because now we talk of full development. I wanted to say this, that our major problem for a preterm baby is breathing, the respiratory system, because of the factors that assist breathing are not fully formed. And therefore, when we are expecting a preterm birth, one of the things we want to know is that is the facility that the mother is delivering in able to offer breathing support to the baby. So they are wanazaliwa wakihema, if I would say that in Kiswahili, that one of the things they get is respiratory distress. And if you're able to support that breathing as we continue supporting nutrition and our baby continues to grow, then they can survive. So respiratory support is the major thing, and it is one of the manifestation of a preterm child, other than having very thick skin, having a low birth weight, because again, they have been denied the third trimester of intrauterine life, because we have said by the third trimester, most of the organs are formed. So basically, the baby will be depositing fats into its adipose tissue to add weight and also to accumulate adequate hemoglobin that would be enough for the baby to survive outside. So
Awesome.
those are some of the complications that we get, majorly breathing. Again, because their neurological development is still taking place, we lack the reflexes. So they are not able even to suckle on the breast. Even if the mother gives them the breast, they'll not be able to suckle. Therefore, we assist them by having a feeding tube so that it can be the way of giving the mother's milk.
Thank you. You mentioned the skin may not be that well developed. I do appreciate there are layers of fat and layer of muscle and different layering of the skin. So this baby who's born preterm will also have challenges of controlling the body temperature, correct, Josephine?
Yes.
Awesome. Okay. All right. I've seen a question in the chat box. Are there ways to prevent miscarriages? Are there ways to prevent miscarriages? Who would like to take that and briefly, please?
Okay. It will depend on the cause. Sometimes we have factors that are maternal. Maternal factors are what the mother has that could be predisposing her to preterm births. There is a common case of cervical incompetencies. And when a mother has this, then what we see at the hospital is a history of the mother having lost even more than one pregnancy. And at the gestation of, especially at the end of the first trimester, when the baby is growing and is getting weighty. So the weight just allows the baby to pass through the cervix, because the cervix is incompetent. It cannot hold the fetus. But then there's a remedy to that. And usually they are given a stitch to be able to manage the condition and have the baby to term. Other factors could be fetal factors. Maybe the child has a gross congenital anomaly and therefore cannot survive to term. So the causes are varied. Again, there's a lot of stress in the community. We are seeing so many preterm births than we used to see before, and we are told that it is because of our socio-economic state as a country. You'll compare us to a place like the US and you'll find that their preterm births are very minimal. We also have maternal conditions that like the preeclampsia, which is very common, where we described it as the blood pressure going very high. I think it was there, Joyce, in our next slides, the abnormal pregnancies, and these are the things that can cause a preterm birth to occur. Thank you, Joyce. But before we forget, those are questions at the chat box that was talking about alcohol. I don't know if I can handle that now. And someone was asking if there is a danger of taking alcohol in pregnancy, and also saying that our young girls are doing a lot of alcohol, and they say that the baby in utero is craving the alcohol. So sadly, the mother will take alcohol, and it is the baby who will get the higher amount of the alcohol, because it will cross the placenta barrier, get to the child, get to the unborn baby, and the fetus will have this in circulation. Remember, the fetus is still forming their body. Their liver is not even developed. And some of these things that we get into our body then are drugs, even the medications that the mother takes. And that's why we say they should be taken only when it is necessary, the usual medications for treatment, and especially avoided in the first trimester. Now, the alcohol will go to the liver to be metabolized so that it is excreted. But this liver is not even fully developed to know how to work. So there's accumulation of alcohol in the body, and by the time the child is born, the baby comes with what we call an alcohol fetal syndrome. And the baby will present with a low birth weight. They're not able to grow well. It could bring a miscarriage or a preterm birth. When they are born, they have very weak bones and muscles. They have difficulties in growing and developing. They have difficulties managing their emotions. And they become very crampy, crying babies, and you wonder what it is, and yet it was the alcohol. So alcohol is not safe in pregnancy.
Awesome.
Yeah.
Thank you for that, Josephine. I'd actually missed that comment. But yes, thank you for the clarification. I want to believe we had also, I'm not sure if we answered the question on cravings. The cravings in pregnancy, do they indicate nutritional deficiencies? When women want to eat the stones, for example. Joseph, do you want to briefly answer that question? Should a mother just pursue her cravings? I mean, are there an indication of nutritional deficiencies? Is it okay to eat the stones that pregnant moms eat? Very briefly.
Alicia, thank you for the question. Actually, the craving is a symptom. So we need to know we are supposed to have thought of how we are going to treat it. The major problem is how healthy, how clean are those stones that you are feeling like eating. So that's where the major issue is. I think Grace, I think if we can put it on the chat box, I think Grace can be able to expound better so that it comes directly from the expert. Thank you.
Thank you. I'm not sure if she will be able to hop back in, but in case she does, fair enough. But I think the main message here is when we have our diet sorted, the way Lillian had expounded, seek to meet the nutritional needs, then the cravings in the body will be resolved naturally. Mainly I would imagine the stones are being craved for because probably there's a deficiency in calcium. I would just think around it. So have your calcium intake, sorted out, your protein intake in order, your iron and folic acid, in place. Then the body will be, the nutritional need of the mother and the growing fetus, the growing baby will definitely be met. I hope we've answered you, Olive. Awesome. Thank you for the thumbs up. All right. Moving on swiftly. We have talked about these recommendations, basically about the antenatal clinic attendance, the nutritional requirements. We did talk about, I think when you were addressing the antenatal care, Joseph, the issue of vaccination with tetanus toxoid, it should be, I think, 2 for a first-time mom and a booster in subsequent pregnancies. Feel free to interject, Joseph or Josephine. And of course, we have delved into the need for the ultrasound scan and the use of alcohol and other substances, which will affect the baby as well. Now, just to touch on abnormal pregnancy, aside from the miscarriage that we have talked about, an ectopic pregnancy, I have not moved the slide forward. There we go. An ectopic pregnancy can happen where the fertilized egg gets implanted outside the uterus, So I wish I had a picture here with us to show us, but it's okay. So we have the fallopian tubes, and then we have the body of the womb, the uterus, where the baby grows. So if the egg after fertilization gets implanted on the fallopian tubes, then that is an abnormal pregnancy, and for sure that is a medical emergency. It can lead actually to life-threatening bleeding and would need to be terminated to save the life of the mother. A molar pregnancy here is where you have abnormal growth of cells taking place in the uterus as opposed to a viable fetus, a baby. We have quite a bit in this sitting and in the previous one discussed fetal abnormalities, some of them developing because of a shortage of specific nutrients in the mother's diet. I think last month we talked about folic acid or folate, which is available in green vegetables. When a mother does not have enough of this, sometimes the spinal cord of the baby is not formed very well. So you have issues like a condition called spina bifida, where part of the spinal cord is exposed on the back of the baby. Sometimes even the brain may not be well formed. So these are some of the structural abnormalities, and these will easily be picked up, especially in the first ultrasound that the lady will have in her first trimester. Medical conditions, sorry if I'm rushing a bit, it's just in the interest of time. I wouldn't want to keep you longer, but medical complications affecting the mother, that will definitely affect the baby. We've alluded to a couple of these in our discussion today. We have diabetes in pregnancy. If someone has diabetes before getting pregnant, or there's a history of the same in the family, then yes, it would be important to pick out early in pregnancy. Remember when we looked at the antenatal care, the antenatal visits, we did talk about checking for the random blood sugar. These are some of the pointers that will guide us to already start suspecting these conditions are present in the mother. There is preeclampsia. Preeclampsia is severe high blood pressure in pregnancy, coupled with other signs that we will see in the mom, aside from the blood pressure. And it's not blood pressure from one reading. No, it is blood pressure observed probably over 2 or 3 readings and more than one visit. There's, of course, the swelling of the hands and the face, and also an abnormal weight gain. We've discussed why checking for or the presence of HIV and sexually transmitted infections or diseases and sepsis in the mother will definitely influence the development of this baby. Now, I want us to just briefly mention what are some, even as we bring this to a close in the next 5 minutes, bear with us. What are the warning signs and symptoms that a mother should be careful to observe for, and it would cause her to want to seek immediate medical attention? Josephine, kindly briefly take us through this as we wind up.
Okay, I hope I'm still audible. So these are the warning signs and symptoms. This is what we want to say when you experience this. You should not continue being comfortable. You should actually leave immediately for hospital. Vaginal bleeding. Bleeding should not occur during pregnancy. Some mothers or even our teenage moms might think that they are still getting their menses. There's no menstruation that occurs during a pregnancy. And this is a sign that labor has started or there's something abnormal, like an abnormal placement of the placenta. And especially when the placenta is lying low in the uterine cavity near the cervix, where we say it is a placenta previa. The other thing that could occur on the placenta is a separation. Now, when the placenta separates from its place of attachment on the uterus, then it's a placenta abruptio, and that is bringing a miscarriage already. And it is very serious because we lose the baby and the mother, because the bleeding occurs from large vessels, which is directly from the uterus to the outside. And the uterus is really supplied with very good it's richly supplied with blood, so that is dangerous. Severe abdominal pain. This again could tell us that the placenta has separated or labor has come in. Persistent severe headaches again could be because of the blood pressure might be very high, but you're at home and you don't know exactly what your blood pressure is, but you're experiencing a severe headache. We also have clots that form and travel around the body. So when you get one into the brain, again, it is very painful. So this one is a danger sign that needs to go to hospital. And if a pregnant mother comes with a persistent severe headache that has no other cause like a blood pressure or anything, then a CT scan is done to be able to rule out some of these things. Then blood vision, where you cannot see well, maybe the blood pressure has gone up, or maybe the blood pressure again may be very low, because sometimes we have concealed bleeding. The uterus is actually bleeding, but it's not coming out for you to see. Sudden swelling, especially of the hands and face. This is what we were describing as a preeclampsia, and sudden weight gain because of the water depositing in the body, in various compartments of the body. Measurement of a high blood pressure. This one needs an urgent admission and treatment. The number of reduced fetal movements after 20 weeks of gestation reduces, then this is a danger sign to the fetus, and therefore monitoring should be done. Severe nausea and vomiting, again, will interfere with how nutrients are taken into the body and how they stay in the body. That's how it's a danger sign. If you suddenly develop difficulty in breathing, then also it's not good and safe for the mother. If the mother has a fever, it's an indicator of an infection in the body, and infections are very good in bringing preterm labors. It could be malaria, it could be bacterial or viral, or whatever other source of infection that could have gotten their way into the mother's body. Breaking water, amniotic fluid needs to be intact throughout pregnancy. So when the water breaks is a danger sign, and if a mother gets fits or convulsions, then it moves from what we call pre-eclampsia to eclampsia. Eclampsia is marked by convulsions. Thank you.
Awesome. Thank you very much, Josephine. So at whatever gestation, and gestation here simply refers the age of the pregnancy, at whatever point in time in your journey as you are expectant, whenever you're not sure of something, please reach out to the healthcare provider. You'd rather just inquire and be safe than not inquire and, have complications showing up that could easily have been prevented. Yeah, and I just want to say thank you very, very much for making time to be here today. We appreciate your presence, and we value your feedback. We value your questions. And I have put a link to a form just to get your feedback on today's session. And hopefully, at least you have one takeaway that you can take with you that will help you as you prepare for pregnancy, or you can even help somebody else who's already on this journey. I do appreciate, like we mentioned earlier on, teenage pregnancies are here with us. Our girls, even as young as 10 years of age, are getting pregnant, and that comes with a lot of other complications, just by virtue of the fact that their bodies are still growing. So it's quite risky for them even at that age. So I'd like to bring this to a wrap today. Next month, we hope to delve into a bit more of some of these conditions we've mentioned as featuring in abnormal pregnancy, some of the medical conditions that can complicate the pregnancy. Issues to do with the high blood pressure, which we're also referring to as preeclampsia, although just a high blood pressure in pregnancy does not necessarily qualify for preeclampsia. When you join us next month, we will explain in detail. We also will tackle bleeding in pregnancy and also postpartum, what is referred to as postpartum hemorrhage, which is actually one of the leading causes of the loss of women in not only in Kenya but also globally. We will also touch on diabetes in pregnancy, and hopefully also make time for sepsis infection. How can this affect a mother and her baby? Do we have any question, any reaction from our audience? Feel free to raise your hand. If not, I will ask for a very, very brief parting shot from Josephine and Joseph as we bring this to a close in 30 seconds. Joseph, go first, and then Josephine, you can conclude.
Thank you, Joyce, and our participants. We are happy to have gone through this session, and there is a lot. We have a lot of information. Sometimes time is the limit, and we believe we are going to give more inputs any other time that somebody has a question. We would be able to be answering even in our consecutive presentations. Thank you very much. Yeah.
Josephine?
Thank you, Joyce. Thank you, Joseph, too, for coming, and for our other panelists, and also to our participants. Just want to urge you to invite someone. Don't come in alone, so that we can continue to share knowledge. Thank you. Be blessed.
Thank you. So the link to our feedback form is on the chat box. Kindly, it's about 5-6 questions to understand how the impact of this session that we've had. So thank you. And we have the same meeting link for next month. So you can save it somewhere and be able to just log back in on the 4th Saturday of the month from 8 a.m. to 9:30 a.m. Thank you. Enjoy the rest of your day. Bye-bye.